Hello, I am Richard Bogan, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 2 of this 4-part CMEO Snack series detailing highlights from the Sleep 2021 meeting. Today's episode is titled Cardiovascular Comorbidities in Narcolepsy, the latest insights on treatment options to mitigate risks. This CMEO Snack series is supported by an educational grant from Jazz Pharmaceuticals Incorporated and is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I am Richard Bogan, president of Bogan Sleep Consultants, LLC. I am also an associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm pleased to be joined today by Viren Summers, consultant in the Division of Preventive Cardiology, Department of Cardiovascular Medicine, as well as the Alice Sheets Marriott Professor of Medicine at the Mayo Clinic College of Medicine and Science in Rochester, Minnesota. Welcome, Viren.
Thanks, Richard. I appreciate being a part of this.
Great. Welcome today. To frame today's episode, let's start by reviewing our learning objective, which is to personalize treatment selection for patients with narcolepsy with or at risk for cardiovascular comorbidities. Patients with sleep disorders often present with various comorbidities which can impact management. Viren, what have we learned thus far about the cardiovascular impact of narcolepsy?
Well, Richard, we started understanding the cardiovascular risks of narcolepsy from the BOND study, which originally was led by Jed Black, and subsequently work from O'Hayan and colleagues provided some further confirmation of the fact that if you look at patients with narcolepsy, they have a substantially high likelihood of prevalent cardiovascular disease. Prevalent meaning at the time that you see them, if they've got narcolepsy, they probably have hypertension or stroke or heart disease or high cholesterol. Subsequent to this and building on the results of the BOND study and O'Hayan's work, we did the CV BOND study, where we looked not just at comorbidities of narcolepsy, but also the incident or development of new cardiovascular disorders. And again, we found that cardiovascular problems like MACE, which means major adverse cardiovascular events, or stroke or heart failure, was increased in patients with narcolepsy compared to matched controls without narcolepsy. So 2 things to take from this. If you have narcolepsy, you are more likely to have an existing cardiovascular problem. And if you have narcolepsy, you have an increased risk of a future cardiovascular problem. Now to clarify, all of these are based on claims data. So they're observational data. They're not your classic randomized longitudinal study, and they don't necessarily mean that narcolepsy is causing a cardiovascular problem, and that may be true, but that's not what we can definitively conclude. All we can get from these data is narcolepsy is associated with an existing or a future cardiovascular disease.
Good point. This is observational, and we have some other posters that we reviewed talking about orexin and the effects of orexin on the body functions, not only alertness, but other functions. So it'd be worth the viewers to actually review some of that information.
Mm-hmm.
Thank you for pointing that out in terms of the relatively high incidence and risk of cardiovascular disease in patients with narcolepsy. As we look at some of the treatment options for narcolepsy, we have to consider the cardiovascular risk that they may impose. Many of the agents that we use actually are stimulant types of medication. In fact, modafinil, armodafinil, the class 2 stimulants, methylphenidate, and the amphetamines those can have, through their alerting process, some increase in sympathetic activity. Of course, we have solriamfetol, which has a different mechanism of action through dopamine and norepinephrine reuptake inhibition. But these through this alerting process may have some effect on sympathetic tone. The interesting thing about solriamfetol is that it's, again, renally excreted, so we don't see drug-drug interaction through the CYP enzyme systems, which is important in terms of birth control. Also, the dosage is a maximum approved dose is 150 milligrams and has low abuse potential based on some of the studies looking at abuse potential. Of course, we have other drugs such as pitolisant, which works through histamine. It is not a scheduled drug, but in a study of patients, there was no real EKG changes, but it does have an effect on the CYP system. So if you have a drug that is a strong inhibitor of the CYP metabolism, you could have an increase in the pitolisant level, which could have an effect on the QT interval. And then we have the issue with oral contraceptives as well. Of course, one of our mainstays of therapy, that's actually a standard of care, are the oxybate molecules. And we traditionally have used sodium oxybate, and sodium oxybate at the highest dose, around 9 grams, is over 1,600 milligrams of sodium intake per day, which is an issue when we begin to think about cardiovascular risk. And now we have lower sodium oxybate, which is a calcium, magnesium, potassium formulation, and this has 92% less sodium. So as we begin to pick out these medications, the classic stimulants, modafinil, solriamfetol, pitolisant, the oxybate preparations, we have to consider how the patients respond and monitor their cardiovascular systems in terms of any potential risk. Varen, understanding the comorbidities and risk factors in patients with narcolepsy is essential for optimizing treatment. You were involved in a key study on this topic presented at SLEEP 2021, a poster titled Cardiovascular Burden of Narcolepsy Disease, the CV Bond, a real-world evidence study. Can you tell us about the study design?
So thanks for bringing up the study, Richard. So essentially what we did was we looked at people from a claims database, from an IBM database that included both Medicare and commercial database information, and it basically told us if people had a diagnosis of narcolepsy and if they'd been treated with narcolepsy drugs. And essentially, we identified people who for 6 months had no specific diagnosis of a cardiovascular disease prior to entering the study. So that blue panel shows 6 months outcome free. For example, if a patient had no stroke for the period of the 6 months prior to entry, we then followed them up to see if they developed a new stroke during the course of follow-up up until June 30th, 2019. If we take people with major adverse cardiovascular events, we first ascertained that there was no record of a major adverse cardiovascular event in the 6 months prior to entering the study. Then at cohort entry, we followed them up until June 30th, 2019. And using this, we were able to get a reasonable idea as to whether people with narcolepsy compared to those without narcolepsy had an increased risk of a specific cardiovascular or cardiometabolic event during the period of follow-up.
Excellent. I mean, it was a large number of people, I know, and you're going to talk about that, but what did you observe relative to the baseline comorbidities of patients with narcolepsy compared to the matched controls without narcolepsy?
So essentially, it was a large number, as you identified. We had about more than 12,000 narcolepsy patients, and we matched them on a 3-to-1 basis with patients without narcolepsy. And essentially, we confirmed the data from the prior BOND and Ohio studies in that the mood disorders, anxiety disorders, migraines, restless legs, sleepiness, and very importantly, sleep apnea were much more prevalent in patients with narcolepsy than in people without narcolepsy. So narcoleptics start off with a portfolio of of central nervous and other disease conditions that seem to be putting them at increased risk for the future, particularly sleep apnea, I might add.
Mm-hmm. Yeah, that's important. I think it's really incredible to see the often several-fold increased incidence of both psychiatric and medical comorbidities in patients with narcolepsy compared to the matched controls without narcolepsy. Uh, what did your group find specific to newly recorded cardiovascular comorbidities or events?
Um, in an unadjusted analysis, we found that the new events were increased in people with narcolepsy. Now, here we see comorbidities like pulmonary fibrosis, prior cardiovascular disease, diabetes, hyperlipidemia, renal impairment. And from those perspectives, you can see that prior cardiovascular disease was higher by about almost twofold. Diabetes was about a 50% increase in likelihood, as was hyperlipidemia. So again, this adds to the concept that people with narcolepsy have a greater prevalence of risk factors that would lead to future disease.
Brent, thank you for that discussion. There's some more data to look at in terms of the incidence of new cardiovascular comorbidities and events from this study. And as you can see, what we saw in evaluating these individuals, looking at multiple disorders, cardiovascular disorders, stroke, atrial fibrillation, renal impairment, any cardiovascular disease, when you compare narcolepsy with matched non-narcolepsy patients, we see a higher incidence. Now, again, as you pointed out, this is observational data. It's not cause and effect. But what we see is that there's an increase in prevalence of these individuals or incidence of new cardiovascular comorbidities in the narcolepsy patients. Another way to look at it is hazard ratios for new cardiovascular comorbidities. This is a statistical methodology to see if there's a real signal that's statistically significant when we examine incidence. And when you look at any stroke or edema, heart failure, ischemic stroke, or any kind of cardiovascular event, MACE, renal impairment, atrial fibrillation, again, we see, or combining atrial fib with stroke or edema as a group, we see some signals there that separate the individuals in terms of narcolepsy compared with matched controls, which is very interesting. Again, observational data, not cause and effect, but we take that into account when we treat our patients with narcolepsy in terms of these potential comorbidities. Yes, thank you, Virend. It's a great discussion on this very informative study. Again, as you pointed out, the limitations, it's observational, but it's also important as we begin to explore the pathophysiology of this disorder, particularly type 1 and orexin, and how does that fit. Mm-hmm. It just opens up more questions in terms of how we try to understand this. It is essential to understand comorbidities and risk factors in people with narcolepsy in order to optimize treatment outcomes. Incidence rates of cardiovascular comorbidities and events are higher in patients with narcolepsy compared to matched non-narcolepsy patients. Specifically, patients with narcolepsy have a higher incidence of any stroke, any cardiovascular disease, ischemic stroke, chronic kidney disease, edema, heart failure, atrial fib. So all these need to be taken into account as we manage patients over time and we select the medications. Virend, thank you for a great discussion on this very informative study. Would you like to add any concluding remarks?
No, I think we've covered most of it. I think at this point, only things we can be certain of is patients with narcolepsy have a high prevalence of a number of disease conditions. They seem to be at a higher risk for future disease conditions, but whether it's narcolepsy per se or whether it's the underlying comorbidities that increase their risk, we don't know. And the last thing is that the role of narcoleptic medications in outcomes in narcolepsy really need more focus.
Yeah, I think these are very important points. Now, so let's wrap up with our SMART goals, that is actions that we hope you can use in your practice. And they are assess patients with narcolepsy for cardiovascular comorbidities and risks that may impede patient outcomes. Consider cardiovascular comorbidities and other risks during treatment planning for patients with narcolepsy. Identify and incorporate into practice treatment strategies that mitigate cardiovascular risks or limit the exacerbation of cardiovascular comorbidities. Please visit the Sleep Disorders Hub at cmeoutfitters.com for a wide variety of additional activities and resources on sleep disorders for both healthcare providers and patients. This has been episode 2 of the 4-part CME Snack series detailing key highlights from the Sleep 2021 meeting. We hope that you will take advantage of the additional short, focused activities in this series. We will discuss key studies highlighting the safety and efficacy of lower sodium oxybate in the management of idiopathic hypersomnia, as well as key findings on dosing and titration strategies when managing narcolepsy. To collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. Friend, again, I would like to thank you for sharing this latest data on the significance of cardiovascular comorbidities associated with narcolepsy. Your perspective as a cardiologist has been quite insightful when informing treatment decisions when managing narcolepsy.
It was a pleasure, Richard. Thanks for the invitation.
And of course, I would like to thank you, our audience, for participating and for providing the best care for your patients. Take good care.